Doctor Yousny, que es el jefe de departamento y profesor del Hospital Nacional de Neurología y Neurocirugía de Londres y miembro de la Sociedad Europea de Neuroradiología. Dr. Yousny.
Yes, thank you very much.
Thank you.
This morning we will be speaking about the microhemorrhages or the microbleeds. And I have here to thank especially Professor Jäger from our institution as well as Dr. Hoskoti Chandrasekhar, who had a great impact on this presentation. So, starting, what's the definition of microhemorrhages or microbleeds? We mean by that small areas of signal void, about 2 to 5 millimeters in diameter, but not more than 10, and they are typically associated with blooming on T2 star or on SWI images. They are seen to be a perivascular collection of hemosiderin-laden macrophages. There are some papers which showed the difference or showed the correlation with the histology, but not many. So when do we see the microhemorrhages? We see them with successful or normal aging. So 20% of people aged more than 60 have them without any associated clinical signs or symptoms. It increases to 1 in 3 for individuals who are older than 80 years. Then we see that in small vessel disease, in sporadic form, but also in the inherited form. And this will be the main topic of this presentation, the cerebral amyloid angiopathy, as well as the other form of small vessel disease, hypertensive arteriopathy. And then we have the inherited forms, and here I'll be mentioning briefly CADASIL and then a few other pathologies, such as inflammatory immune-mediated small vessel pathology. We have here CCA-related inflammation, or ICCA, lupus, endocarditis, and a few others. So what is the real cause of those microhemorrhages? In small vessel disease, we have leakage through the small vessels, and we also see that in cerebral amyloid angiopathy, so CAA, where we have deposition of beta amyloid in the vessel wall in those vessels which supply the cortex as well as the leptomeninges. So small vessel disease is actually quite a common syndrome. It has a big clinical effect. It's associated with disability, cognitive, psychiatric, physical, so all kinds of disabilities. It's related to stroke in 20% and doubles the risk. So anyone who has evidence of small vessel disease, the chances of that person to get a stroke is doubled. And it contributes to almost half to almost 45% of the dementia patients. So our problem with small vessel disease is that it's not straightforward in terms of investigating and imaging, because the cause is really unknown. The real cause is not completely clear. The prevention, therefore, we don't know really how to prevent it from happening, and also we don't know really how to treat it. So it's all a bit of an unknown journey, but we know that the impact on the society, on the individuals, and on society is huge, and something needs to be done. So we have a sporadic, intrinsic process of the vessels, which affect the small arteries and the arteriole, the capillaries, small veins, and is clinically often silent in the first stages of the disease, and can develop over years before anything becomes manifest from a clinical point of view. For those who were here yesterday, I mentioned this yesterday, the type 1 and 2 being the most frequent ones, the one here, the arteriolosclerosis, which I expanded on yesterday, and the CAA, the cerebral amyloid angiopathy, is the sporadic form, but also the hereditary form, and then we have CADASIL and other forms. So in the first form, briefly, because I expanded on this yesterday, we have arteriolosclerosis affect the smooth muscles, deposition of fibrohyaline material, narrows the lumen, thickening of the wall vessel, and not to forget it's a systemic disorder. And you have here the deposition of the lipohyaline, and you can have atheroma and also microaneurysms. The pathology itself, the basic pathology, cannot be visualized, but the consequences can be visualized. And these are the 5 points: white matter hyperintensity, that was the focus, but also recent subcortical infarcts or lacunes. Then microhemorrhage is the topic of today, but there is an association with perivascular spaces and volume loss or atrophy. And just to remind you that the pathology and the distribution of pathology can be explained by the characteristics or the different characteristic of the vessel walls. So we have in small vessel disease of the first type, affected is the perforators coming from the cortical vessel, to a lesser degree the basal ganglia, where with CEA it's mainly the leptomeningeal and cortical arteries. So what's the difference? The difference is when you go down here that you have in the basal ganglia more than one level of smooth muscle cells. You see you have here two, whereas you have here only one. That's one difference. The other difference is that you have here still some tight junction, whereas the junctions here are not so tight. So that means this here is more protected than this here, which is more vulnerable to leakage, any kind of leakage. And then the perivascular spaces, which are fluid-filled by definition, also known as Robin-Virchow spaces. They should have a signal intensity similar to CSF, but there's a lot of debate about that. Also, the terms come here of glymphatic system, and there are a lot of discussions how it really is configured. So, depending on how we cut, the perivascular spaces can be linear, or if we cut them orthogonal, then there will be round, like you see that here. So this form of small vessel disease displays microhemorrhages, both in a lobar form, here posteriorly, and in the deep form. With deep, we mean the basal ganglia, the area of the gray matter. And this is in this cartoon, where you have affected both cortex, subcortex, lobar, and the deep here in the region of the basal ganglia supplied by the perforators from, for instance, the MCA. So this form of small vessel disease, the arteriolosclerosis, is defined by recent small subcortical infarcts, white matter hyperintensity, lacunes, perivascular spaces, and these microhemorrhages. A special form of and hereditary form is CADASIL, which is cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. As I said, it's a small vessel disease, which is an arteriolosclerosis, but it's hereditary and related to a mutation in a certain gene, NOTCH3 gene, in chromosome 19. So the special thing here about CADASIL is that it starts quite early. Patients are in their late 20s, 30s, and slowly becomes symptomatic. It was first described starting in the 70s, but at that time it was thought to be largely demyelination, a special kind of presentation of multiple sclerosis. It was later on that it was discovered that it was actually a small vessel disease and not MS. And the characteristic thing is, in terms of imaging, that the temporal lobes are spared. So you have widespread changes around the ventricle or subcortical, and you see here that the U fibers are spared. Here the external capsule and extreme capsule are involved. The brainstem is involved, but you don't have anything anterior to the temporal horns. So that would be a way of differentiating, for instance, the hereditary form, CADASIL, from the sporadic form, small vessel disease, where you have here anterior, where you have involvement of the temporal poles anteriorly. This should not be CADASIL, and this will then be small vessel disease, and the other way around is true. There's one more thing that has been described, which is these small areas of hypointensity on T1, which are along the cortex, but here also along the insula. They were described as subcortical lacunar lesions. They are probably enlarged Virchow-Robin spaces, and they have been described in CADASIL. But coming to the microhemorrhages, you see also here widespread changes, and here the microhemorrhages, infratentorial and deep, and it will also be in the lobar form. So the same thing that we have in the sporadic form, we also have here in the hereditary form. And the distribution, as you see, this is a kind of a fingerprint, which shows you involvement of the deep, the thalamus and the basal ganglia, and here the brainstem, cerebellum a little bit, and then mostly the occipital and posterior temporal forms. So moving that to the second form, which is the cerebral amyloid angiopathy, the clinical presentation is usually becomes symptomatic by a hemorrhage, an intracranial hemorrhage. And hemorrhages, spontaneous hemorrhages, 20%, 5 to 20%, depending on the paper, are caused or related to CAA. It also relates to an impairment on cognition and then to dementia. It can be quite rapidly progressive and relate to neurological decline, but there can also be transient symptoms. So that's one example, for instance. You have here a hemorrhage occipital, and you see on the SWI the microhemorrhages posteriorly, but also a bit anterior. So this is a lobar distribution. So a hemorrhage with microhemorrhages in a lobar distribution would support CAA. On the other hand, you have this one here, another patient with a hemorrhage, again, lobar hemorrhage, and you see here maybe microhemorrhages, yes, but also here this black lining, so hemisiderosis in the region of the central sulcus, but not only that, so superficial siderosis, cortical superficial siderosis, which is also associated with CAA. So typical presentation would be a lobar hemorrhage, here with subarachnoid hemorrhage. The subarachnoid hemorrhage can be seen also on the SWI. Here's this slight hyperintensity. In this case, you have also the hemosiderin, the siderosis, and you have here microhemorrhages or microbleeds. And on this one, you have here the associated hyperintensity of the white matter and also small acute infarct with restricted diffusion. So the manifestation on MR are microhemorrhages, white matter hyperintensity, convexity subarachnoid hemorrhages, cortical superficial siderosis in a quite a large proportion, and silent acute ischemic lesions. So the acute subarachnoid hemorrhage is typical cortical. So when we have that kind of distribution, we don't need to think about angiography, we don't need to think about aneurysms or AVMs. It's a typical distribution for CAA. And if you do SWI, you will see in addition to the acute hemorrhage, most probably you will see also superficial siderosis and then some microhemorrhages. So the cortical superficial siderosis is different from the typical classical infratentorial superficial siderosis, where patients present with a long-standing history, maybe of vestibular symptoms and infratentorial symptoms. And there you have the hemosiderosis around the cerebellar folia and the cranial nerves. So this form is most frequently associated with CAA. There can be, like always, other etiologies, surgery, trauma, a ruptured aneurysm some time ago, and so on. So the detection, of course, is difficult with T2, especially most of us are using the fast spin echo, which is not very sensitive to susceptibility changes. And it's so easy and straightforward to see with the T2 star images, and more so with the SWI images, where you can see the extent of it much more better. So putting these changes together, and that's a very nice cartoon showing the siderosis that you see here, for instance, the microhemorrhages, which are here, microhemorrhages, and then the subarachnoid hemorrhage can be everything together. You see here also enlarged Birkhoff-Robin spaces, which belong to that. This can also be seen on pathological workup. These were patients passed away. So you see this is a microhemorrhage, but an acute one. Here you have the siderosis within the cortex and some deposition of iron around the vessel. And here you have a microinfarct. So the microinfarcts are difficult to see on MR, but the others are very well visualized. And that brings you to a theory how the whole thing develops by having a defect developing in the vessels. So you have a vascular injury and a damage, which is in part related to the deposition of amyloid. You decrease the vascular compliance, you get lesions, leakage, injury of the brain, the whole thing increases. you get the deposition in the perivascular space increases, you get less of clearance, which means more substance goes out and you have a progression of the disease. Not all of these parts have been proven, but that's a very good workable theory. So to make the diagnosis, there were criteria developed. It's the so-called Boston criteria, which are dependent on the number of hemorrhages, the age, the size, and the clinical presentation, symptomatic or asymptomatic. And this is the modified form, where you have, to make the diagnosis of definite, it must be postmortem. So that's beyond us. We are the experts of in vivo. So definite and probable with supporting pathology, this can be if you do a biopsy. We most likely are dealing with cases where we could come up with a diagnosis of probable or possible CAA. And here, this is determined by the presentation. Multiple hemorrhages restricted to lobal, cortical, or subcortical regions, or single lobar. Age above 55, absence of other causes of hemorrhage. But quite often the patients come on with CT, and many of us would, patient with a hemorrhage, acute presentation, will do a CT first. Can we deduce anything in terms of CAA from a CT? And this group said, well, if you look at those three criteria, the present absence of subarachnoid hemorrhage, if you could work up or get information of the APO presence, and then what they describe as finger-like projections of the hemorrhage. And then if none of them is present, or if two or more are present, so that's low, that's high, and if you have only one, that's the medium thing. So if nothing is there, then you can rule out, with a very high sensitivity, you can rule out CAA. If you have two or more, such as, this is what they mean by the finger-like projections, that you have that kind of appearance on these two. So finger-like projections here is positive, and you have here subarachnoid hemorrhage. Here you have all three cases. Here they don't have, or they don't know the ApoE, but they have the other two, subarachnoid hemorrhage and finger-like. So with a very high proportion, this will be CAA. And in the middle, well, you have a problem. But that's always the case. It's never black and white. But that's, I think, a very nice, recently published workup that could help us in the daily routine. Coming back to the microhemorrhages, they can be seen here at worked up specimen at high field strength. We can see it obviously with the histology. We can see the staining, the iron, and the deposition near the wall of the vessels. The prevalence of the distribution of the lobar distribution decreases. It's mostly occipital and then frontal, temporal, and parietal. Jump this. And the distribution, I mentioned it earlier. So small vessel disease, as I said, is lobar and deep, and CAA is lobar. And this could help us in differentiating between those two forms of small vessel disease. And that was a PET study, and they showed that the lobar distribution relates to CAA, and the lobar and deep distribution relate to small vessel disease. And I'll jump that. So that is one other recently published work where you have all these changes which are typical for CA, superficial siderosis, acute hemorrhage, and you have some microhemorrhages. So you have here PET positive, so that speaks for CA. In this case, you don't have any deposition of PET tracer. And you do see a little bit of hemorrhage of the siderosis, but that would not be positive for CA. That would be more inclined to small vessel disease, arteriolosclerosis, because you also have here the deep microhemorrhages. So this form is clear. It is CAA. This form is clear. This is small vessel disease of the arteriolosclerosis type, and this is in between because it shows both characteristics, so it becomes more difficult. So you can relate the chances of getting an ischemic stroke or intracerebral hemorrhage to the number of microbleeds. Obviously, it's small if you only have one, and if you increase, it gets higher. And with LOBA, so with CAA, the chances of increasing the risk is much higher, it's almost 4%, whereas if it is deep, which means the small vessel disease form, arteriosclerosis form, is much less, and the mixed is more than the strictly LOBA form. So from this, you can develop a template by which you separate the two, and you see the MR markers, the microhemorrhages, strictly LOBA for CA, predominantly deep with or without LOBA, superficial siderosis in 40%, quite rare here. Perivascular spaces visible in the centrum, here in the basal ganglia. You remember maybe from yesterday, the état criblé. White matter hyperintensis, posterior dominance, no predilection, so that's a little bit woolly. And that would help you guide the patient in the next steps. From this form, there has been a description of a variation of this, which is an inflammation of CEA. So CEA-related inflammation, where you have infiltration of lymphocytes in the perivascular space associated with edema. It is a form of A-beta-related meningitis with intramural granulomas, usually 60 to 80. Patient present with confusion, cognitive decline, and has similarities with something called ARIA, to which I'll come in a second. So we have white matter hyperintensities, of course, extended subcortical white matter, swelling of the gyrus, peripheral microhemorrhages, and cortical superficial siderosis. It is a form of CAA, and leptomeningeal enhancement. So let's look at this patient, 80-year-old, rapidly progressive confusional state. GCS dropped to 5, and what was suspected from the first images was a gliomatous cerebri. A bit symmetric for that, of course. Now that I said that in this context, you know it can't be gliomatous cerebri. But why? So the trick here is to do the right sequence, like always. And they did a SWI, and of course that's a completely different presentation than the gliomatosis. So on histology, you see changes within the meningeal vessels, the parenchymal vessels, the thickening of the vessels, and the spread of the leukocytes. And amyloid beta is deposited both in the parenchyma as well as along the meninges and around the vessels in the cortex. So you have the amyloid deposition. And then you have the inflammation around the vessels. So you have both here the deposition of the amyloid and the perivascular inflammatory infiltration. The patient improved dramatically after 3 days of steroids, is then kept on prednisolone, and was given cyclophosphamide. And after 5 months follow-up, you see that the whole situation has improved. You don't have these big changes. However, if you look at the first presentation, where you have also volume, increased volume, you have edema and shift of the midline, all this has disappeared, but you also see that the ventricles have enlarged, the sulci have enlarged, so clearly there has been an important volume loss, important atrophy. And another patient who presented with headaches and flashing lights, again, this time slightly different. It's a circumscribed area in the occipital region, right occipital region, and on SWI you see the microhemorrhages. So with time, so that was in March 2016, this is in July 2016, this has spread, has increased a little bit, and also the microhemorrhages have increased, and you see also the leptomeningeal enhancement. So it all fits with the inflammatory form of CEA, which was proven by brain biopsy. So from this, again, criteria were developed to say probable or possible with a high specificity and sensitivity, which, like before, age plays a role, the clinical features, and the MRI characteristics. And ARIA, which is amyloid-related imaging abnormality, is something that we observed as consequence of treatment, especially with patients with dementia. So observed an amyloid-modifying immunotherapy. And what we see, we have two forms. One is where we have more edema, and one where we have more hemosiderin deposition. And see here again, this is the form of edema. You will see this more the edema form in carriers of the APO4 gene variation. Has been seen in trials. It's one of the problems that when you do MR to follow up in a trial that you have to be aware about. Now, 2 or 3 more cases where microhemorrhages have been described, like here vasculitis, obviously not only disc vasculitis. You see here enhancement in the region of the right optic nerve, and you see here microhemorrhages, infarction, a microhemorrhage here. So bacterial endocarditis, this could be seen on SWI images. The trick is always, do you do the sequence? Is it part of your protocol or not? In a patient with sepsis, you see the widespread changes in the lobar and also in the deep form. And also in this TTP, where you have some microhemorrhages, both deep as well as superficial. Lupus presents in 13%, the neuropsychiatric form of lupus, in 13% also with microhemorrhages. How much this could help in the differential diagnosis, I'm not so completely sure. But in this patient, for instance, who has lupus, started with a CT, and on the MR, you see here this hemorrhage, but also some microhemorrhages and some enhancement. So I would like to conclude to say that microhemorrhages have been getting more and more attention, as you know. It is important, the 2 forms of small vessel disease. It's important to know the distribution and the relevance in terms of lobar versus lobar plus deep, or the 3rd form, the mixed form. I think the fact that this is associated with the cortical siderosis is something we need to keep in mind. There are increasingly cases being described with the inflammatory form of CCA, where you see widespread microhemorrhages, and of course we are aware and we know that patients with different other presentations can also show microbleeds. The challenge here is to find a compromise between increasing the time of the protocol and the indication and the pressure that we have in our departments. Thank you very much.